There are a number of legal and policy approaches that we have both adopted or are available to address the opioid epidemic. I would say most of the activity has happened. There are a number of legal and policy approaches that we have both adopted or are available to address the opioid epidemic. I would say most of the activity has happened at the state level and among localities thus far. So at the state level, we've had, I think, probably since 2010, close to 1,500 bills introduced related to opioids, and probably close to 500 have been adopted and enacted. So that's a lot. and so states are, I think, scrambling to some degree and trying to enacting a lot. And we're trying to evaluate as quickly as we can what's working. And a few leading policies have emerged as potential tide changers in the opioid epidemic. So one is one that I study, that's prescription drug monitoring programs. The use of these databases, they started out as law enforcement databases, but then shifted and morphed into clinical databases. Again, these aggregate all of the controlled substance prescribing, or most of it, at the state level. And so the idea is that a prescriber would log into the system as they're, before or as they're seeing the patient, see what their history is of controlled substance prescribing for the past year or two, usually is in the database, and know, has this patient been frequently obtaining and filling prescriptions for opioids in the recent past? Are there potential polypharmacy concerns? So that would be drug interactions. One particular interaction of concern is with benzodiazepines, because that combination of benzodiazepines and opioids is a high risk factor for overdoses. So it's sort of a full picture of what the patient has been getting on the drug side, that all of that information would not be available within an electronic health record or electronic medical record, because that would typically be only the provider and that system level database, and not all of that information is being shared among providers within a state. Also, in the prescription drug monitoring programs, or PDMPs, I'll call them, there is sharing of data across states increasingly. So if patients are traveling across state lines to try to fill opioid prescriptions in another state, that would be captured with increasing frequency. But we've identified some policy levers for first that get prescribers to actually use the databases. So use mandates that require that they check the databases under pretty comprehensive circumstances. For example, when they're seeing a new patient, when they are prescribing opioids for chronic pain, every 3 months they have to check it. So a number of states, about almost half now, have some kind of a use mandate, and that's, has some comprehensiveness to it. And that, we've shown, actually does reduce opioid prescribing, does reduce overdoses. So that's a effective policy lever. We do know that 4 out of 5 heroin users, for example, did start out with prescription opioids. So some of these state level interventions that I'm talking about, like PDMPs, also regulating pain clinics that prescribe painkillers as a main portion of their business, those are two state features that seem to have really contributed to this reduction in opioid prescribing. It's still high because it's still 3 times the level that it was in 1999. So we still have a ways to go, and there's a lot of variability. So some states have 6 times the prescribing of other states by most recent estimates. So we still have a problem there, but what we're actively researching now is how much are some of these policies that have contributed to reductions in prescribing contributing to this spike in heroin use and fentanyl use and overdose deaths related there.